Okay, committee, bring the meeting to order. And as many of you know, we were where we left off yesterday in discussion with Larned Hospital. Who do we have on Zoom here? Yeah. I think we have some continuing discussion with Larned from yesterday. Is that right? Director Berner?
Oh, sorry, Mr. Chairman. We can continue where we left off yesterday. I think Superintendent Dittman was done with her presentation and we were taking questions from the committee. You sent a couple this morning that I could respond to if you'd like, or I'll follow your lead on where how you'd like to proceed.
Go ahead, respond to the two that I sent you this morning.
So one question was about the difference between the state security program and the state psychiatric services programs, and why those populations have to be separated in their residential units. I sent to the chairman the statutory references that talk about the need for separation of the populations by kind of the reasons there at Larned, whether it's for forensic evaluation or for psychiatric treatment or in the sexual predator treatment program, which drives the need. Well, that's why we have separate housing units for them now, and also the need to have separate housing units for isolation and quarantine related to COVID. And I can happy to share that with the committee more generally. There's a little more information as well on the differences between the two programs, but I'd let Superintendent Dittman talk about that if you've got more questions. The other specific question you asked was about food service. I think it was related to the reduction that we mentioned and that Matt briefed you on in the budget recommendations. Your question, Mr. Chairman, was if the food service isn't utilized, why we aren't just shutting it down, and maybe the part of the conversation that was missed. Right now, Larned provides the meal services to the correctional facility at Larned. As part of that interagency agreement, we get some services from the inmates in the correctional facility, and Larned State Hospital provides some of those back, and food service is one of them. Corrections is in the process of updating the kitchens in a couple of their buildings on the campus that would allow them to provide their own meal service to inmates and staff on the corrections side. And they're going to use their food service contractor, Aramark, to provide that service. And that's all scheduled, if we've got the timing right, that's all scheduled to turn over in July, this coming July. So it's not that, so our demand on Sodexo, our food service contractor, will go down. That's going to be picked up by the corrections food contractor, and theirs is a little cheaper, significantly cheaper than our food service. So we can save the funds from what we're paying to provide those meals. Corrections has a small increase in their budget to pick up those meals for the same inmates using their vendor. So it's not that it's unneeded. We're just swapping because the needs on the correctional facility are different than they have been. I hope that's a better explanation.
On that subject, so where is the $830,000 that it's going to cost you to the Department of Corrections for that food service?
It's in their budget request. I checked in with with Keith Bradshaw this morning at Corrections, and it's I believe he said it was included in their budget recommendations to pick up that difference. So it's a $3 million savings in our budget. They're adding $800,000 or so. So there's a net savings to the state, but that'll be in the Department of Corrections budget, which you all won't see in this committee.
So it's a $4 million operation.
for us, we're spending about $3 million to provide those meals. It's only going to cost corrections $800,000 because their per meal price is significantly less. We'll still be paying Sodexo to feed the patients and residents at Warren State Hospital, if I'm understanding your question.
Okay. Committee questions? All right.
And Mr. Chairman, the third question you sent me was to get some more detail on the breakdown of wait times and between the two populations. We've been pulling some of the data together that we use to report out and use internally. I did want to make sure we were answering your questions correctly, so I would respectfully ask if you could maybe give me a couple of sentences on specifically what you're looking for in terms of more detail and to make sure we answer your question rather than scattershot it and then miss the mark.
Well, for instance, here we have on page 11 of your slides for Lone State Hospital, and it states in here that a wait list was necessary 56 of the 366 days, with approximately 13 pending admissions waiting per month for an average wait time of 17.95 hours. So I'm trying to figure that out, how that works. And the chart on the next day shows January, February, March, and April with no wait times, no wait list. And then in April, goes in, and there's still 0 in April, and then in May, it shows 5, June 14, July 16, August 11, down 5 in September, October 9, 8 November, and back up to 16 in December. So I'm just trying to figure out how you calculated that there were no, there were only wait lists 56 days out of 366.
So, Mr. Chairman, the chart that's on the 12th slide of our presentation is capturing the wait list at the end of the month to kind of take that point in time. It is a daily list, so and we could produce for you the daily number of people on the wait list any given day as well. But what you're seeing on that graph is just the capture at the end of the month. And then I think the other part is the timing of when the census change happened because of COVID, and that reflects when you see a waiting list is when it started. But I might ask Superintendent Dittman if she can clarify that or make sure I didn't misunderstand.
Superintendent Dittman.
Thank you, Representative. Looking at the charts, if you look on 12, look at that one. That slide shows the number of patients on the wait list each month. So that's the number of patients. And then if you look at the next one on page slide 13, that slide shows the number of days during each month that the individuals were on the wait list. And then if you add all of those together, there are 56 total days that we had a wait list. So that's where the 56 came from.
So there were some days during the month when there wasn't a waiting list, but this is trying to capture it and show you 1 month at a time.
Correct.
Well, I bet there's a lot of people out there that would disagree with that, but at this point in time, I'm not going to argue the point. Okay, Scott, what else did I have on your list there?
Those were the three, I think those are the three questions that I had, Mr. Chairman. And we could provide the day-to-day waiting list numbers as well, if that would be helpful, just to see the trend over the course of the month. If that month break isn't reflective, I mean, it is a snapshot point in time, so if it would be helpful to see that at a more day-to-day level, we'd be happy to provide that to the committee as well.
I think that would help a lot for us to understand exactly where the wait list is and when it isn't. So, yes, if you would provide us with that information. Committee, further
Happy to.
questions on Larned State Hospital? Representative Lynn.
Thank you, Mr. Chair. Just looking at those different lists, those different charts there, I'm curious because they seem to follow, as you would expect, the same trend, except in November, when you have the 8 patients waiting, 5 days of those where they were waiting, but the average wait time was 36.5 hours. Was that due to the holiday? It seems pretty high for where it's a low number of patients, I guess.
Yeah, I can respond to that. For whatever reason, it was that we didn't have as many admissions. And so then that would result if you have less admissions, less wait time. Because there weren't individuals that were on the wait list.
You're kind of cutting out.
Could you repeat that? I'm sorry, I couldn't understand.
I apologize. Can you hear me now? Is that better? I don't know what the feedback is.
I think so.
Okay. And just to clarify your question was, why were there some days where there were less individuals on the wait list?
No, it's more about how there's 36.5 hours waiting in November when I was just, you would expect the trends to be the same when you're looking at the number of days, number of patients, and even the hours waited. You expect to see a similar trend, but in November, they had to wait 36.5 hours. So I was wondering if that increase in wait time had something to do with, Thanksgiving.
Yeah. I think I understand the question. I think it could be an array of things. I think it could be the amount of time that it took to get the person here from wherever they were, perhaps. We get the screens from the mental health center based off of, the need. And so I'm not exactly sure. I mean, I could look into the individual cases and provide more information. I'm not exactly sure why the difference, but my guess is that it's an array of things and probably specific to each of the individual referrals.
If I may. Okay, that's fine. I was just curious if that was a trend that you see around holidays, I guess, is what I'm thinking, or if that's just an anomaly.
If you would like, I can look for the data on it.
I'm just curious. Thank you. Thank you, Mr. Chair.
Representative Ballard.
Yes, I was trying to follow your thing. That would be a day and a half. When you say 36 hours, so that's a day and a half. So with it being a day and a half, I'm just trying to think that could be, by the time somebody scheduled an appointment, it'd be the next day, but maybe in the afternoon. So, I mean, I'm trying to, that's not very long.
No, I was looking at the fact that it doesn't seem to have any more additional people waiting, and yet they had a longer time to wait. That was my point, was that there aren't additional people, like on some months where there are 9 people, but their wait time is a lot less. I don't know, maybe it's not.
I'm saying you, yeah. Actually,
And Representative Lynn, Scott Bruner, it might, when we look at that day-to-day breakdown, it might be that there was 4 days in a row when there was a wait list, so it took longer to have the discharge, and so that extended the time frame. It may show up more in that day-to-day list than just capturing the month snapshot.
Thank you, I understand, thank you.
Any further questions? Representative Ruiz.
Does anyone track what the admission rates are in local psychiatric hospitals? I know this is kind of a far reach to see how that affects admissions to the state hospital.
Mr. Chairman, we do, if it's a hospital that we work with as a diversion site, so that is one of the contracted hospitals that will take patients that are involuntarily committed. We have a daily count. There's a daily tracking of that as well. For just private psychiatric hospitals, not it's not as intensive, but for those that we partner with as a diversion location, we do have that on a day-to-day basis. But I can ask our counterparts on the behavioral health side if there is another data source that I'm not aware of, but I'm more familiar with what we use as the diversion beds or hospitals that we operate with diversion beds.
Mr. Chair, I have a comment. Representative Lynn, and I work at Advent Health in the psychiatric unit, and we've been seeing similar admissions, kind of, there's been no pattern. And, you know, someday there'll be 7 admissions and the next day, nothing. So, and we've not been able to figure out either what, usually you can predict around holidays. Not this time. We've not been able to predict.
Committee, further questions? Xavier, I'm kicked offline here. I'm not sure what happened, but waiting for the host. Are you off too? Representative Howard. There, thank you.
Thank you, Mr. Chairman. Excuse me, they're at LSH Hospital. You replace those Omnicell machines because of the software. Was that software from Omnicell? Was that COTS, commercial off the shelf, or is that specifically designed for those machines? And since you had to replace them, are you going to use Microsoft and Omnicell again for the new machines with updated software? And do you have a license, or will that have a sundown on it? And at what cost?
Thank you. Regarding the machines, the current, it is Microsoft, and the new machines, they would have updated versions of that. What's on there now is so old that it's no longer supported. I'm not a technical person as far as computers, but my understanding is because of the age of that, it isn't supported any longer, but the new machines would have new Microsoft that is supported.
Your new software from Microsoft is going to have the Windows 10 or the Windows 12 on it, correct?
Correct. It would be an updated version. I don't know the exact version, but it would be an updated version that does that is supported.
And the the Omnicell software will work in conjunction, and Microsoft and this other company are going to work together to make sure that there's no hiccups with these machines. Is that correct?
I'm not exactly sure I understand.
Ma'am, I'm a plus system builder, and I beta tested Microsoft Windows all the way up to 10. If you don't have all of the specific testing done, you can do a pre-release and still have a crash on the software. That's my question. You need to make sure that this stuff, when it's ready to be released, it is secure and it's been fully tested.
Okay.
Representative Howard, it's Scott Bruno with KDAD. So we're in the process of there was an RFP in place to replace all of the pharmacy dispensing systems at all the state hospitals. They're mostly used at Osawatomie and Larned. We're working through that RFP, so we may have a new vendor, but that's part of the specifications that they have to support the most up-to-date security patches and HIPAA compliant and all of those things that the Omnicell machines that we're talking about at Larned are very old and out of date. So the whole concept is to bring the whole both hospitals up to modern standards that are supportable and current with their privacy, security, all those things that you mentioned. So, but I appreciate the call out and we're working with our IT staff as well as we look at those new devices and the software that supports them.
I understand, and I thank you very, very much for that. I just want to make sure we made so many steps forward that you talked about in this bullet. I just don't want to make any backward steps, that's all.
Absolutely.
So thank you
Absolutely.
very much for the information.
You're welcome.
Thank you, Mr. Chair.
Any further questions? Okay, I want to go back to slide 16 on the Larned State Hospital, the SSP, State Security wait list here. And help me understand this, just draw me pictures because I'm pretty easily confused. But I see what I see on here is a wait list that goes from January 20 to December 20. This wait list is 177. Mine's not in color, so I'm not sure which one is which. But the bottom says the darker one is the total number of defendants on the wait list. And then the lighter colored number says the average number of days defendants are on the wait list. And I'm seeing 177, 127. And then if I'm totally not bonkers, that's one of the units that you're wanting to close. So would you please explain that one to me?
Yes, Representative Carpenter, thank you. If you look at the graph, it does have the two lines, and I understand what you said as far as yours not being in color. The line at the end that says 177, that line in color, it's in orange, and that's the average number of days that defendants are on the wait list for each of those months. And so if you look at the beginning, in January it was 86, and in December you can see the 177. And then the next line below that, that is the total number of defendants that are on the wait list for that month. And this graph shows the number of males. Our largest group is males that are on the wait list. And we did close one of the male units. We had a total of units that served the males in these categories. And we did close one of those, and we're utilizing it as an isolation unit for our COVID positive individuals, so that we can isolate them there. One of the things that we're doing is we're trying to work on the mobile competency and trying to encourage courts to order individuals through mobile competency to cut down on that wait list. And so that's my explanation as far as the chart. Did that answer your question?
Well, kind of, except for, so the unit that you're proposing to close has already been closed?
It's currently being utilized. We have a unit that we reduced to utilize it as a isolation unit currently. Yes.
So you don't have those 20 beds that you're talking, or 30 beds that you're talking about closing. You've already done that.
Correct. For COVID, that unit remains closed currently, and the 10% budget reduction did include leaving that as a permanent closure.
So explain to me how this wait list works with closing the unit.
The individuals would continue on the wait list until they had a bed at one of the other units. We have two units. We have a unit that is for the higher aggressive individuals. We have a unit that is for moderate to low aggression or individuals that are vulnerable. And so they would remain on the wait list unless they were going to have their evaluation or their treatment done by mobile competency, and they could have it done by mobile competency versus coming into the hospital.
So where are these people housed now?
These individuals are currently, majority of them would be in jail. There are some individuals that end up out on bond, but majority would be in a jail.
So do we reimburse the local governments for them being incarcerated in their jails?
That's a question I don't know the answer to. To my knowledge, there's not a reimbursement that comes from the state hospitals, no.
Scott, are you aware of any reimbursement to the local governments for housing inmates that we have no room for?
Not from ks. State Hospital, Mr. Chairman.
So the local governments are housing this 100 and, I'm not sure how many, I'm not sure which line's which, but 127 or 177 people out there in county jails until we have time to get them into our facilities. Is that correct?
or do a mobile evaluation where they are, where they're currently located. I think the other part, and we can extend this this chart back into the past. The wait, and I have to look at the numbers, but the wait list has gone up a little bit with COVID. Just as part of it is also there's not throughput on the judicial side. Trials aren't happening. Some of those issues, but that third unit that we are using for isolation was not fully. It wasn't full of inmates or people in the forensic evaluation process before it was closed. We'd also have to staff it, and so we're having issues finding adequate number of staff people to work in that unit before we needed to use it for isolation purposes. But it might have to show some context beyond the last year and with, where we've been with COVID. Just to give you a fuller picture.
Well, I think even before COVID, that's January, there was 80, 86, and I'm not sure again, and 118, and that was certainly before COVID. So
Yeah, yes.
I understand COVID's been an effect on it, but to me, and again, this is my limited knowledge here, it makes no sense to close a 30-bed unit when we've got even if you take out the COVID numbers and go back to 86 and 118, those people are being housed somewhere at someone else's expense. Is that a correct question?
Yes, that's a correct statement.
Okay. So I just want to make sure that we're all clear here and we're all on the same page about what we're doing here. So anyway, committee, further questions? Representative Lynn.
Thank you, Mr. Chair. On that same graph, how are those defendants prioritized for who comes off the wait list? Is it based on how long they've been on the wait list, or is it about need?
It's based off of the order in which they come on the wait list. There is the ability, if one of the jails reach out and identify someone that is really struggling, maybe they're self-harming or something, there is a clinical process that we go through if someone does need to be moved up further to the front of that wait list, but it does go by based on the first person on is the first person that would come off.
Thank you, Mr. Chair.
Committee, further questions? Okay, that concludes our talk on Larned, and we will move on to Osawatomie State Hospital.
Thank you, Mr. Chairman. Superintendent Feedback's ready to present. If I can share my screen again, and I'll operate the slides for her and let her get started.
Thank you.
She on?
Yeah,
She's on, but I haven't been given the ability to share my screen yet. But Kristen, if you want to start working from your notes, I'll catch up when I can broadcast.
Scott, I did notice at the top of my screen it said locked, the meeting's locked, so I don't know if that makes it harder for you to be able to do
I just got it, so I'll have it up here in just a second.
Okay. Well, thank you, Mr. Chairman and committee members. Osawatomie State Hospital has been serving the state of Kansas for 154 years. We serve civilly, criminally, and dually committed adults with mental illness. One of the statistics I just wanted to share with everybody is 82% of our patients on AAC have a co-occurring substance abuse issue, and on our OSH side, 53%. of patients have that. So I just thought that would be worth sharing. OSH has 114 licensed beds. The rooms are semi-private and private rooms, just depending on the unit. AAC has 60 certified and licensed beds, and all those rooms are semi-private. We do have times in which we have a patient that may need a private room due to aggression, and so we do sometimes have to offer that. Okay, next slide. The next slide you'll see is our admissions by county. And the other county category is all the counties other than the ones that are listed there, and that's our highest out of state. If you see that, when you see that category, that means that the patient resides in another state, but the episode happened in Kansas. Next slide. This reflects our patient days. So for 2021, currently we have 7,776 days with an average census of 37. Last year for 2020, we had 13,638 days and our average census was 38, and this is for AAC. Our admissions total for 2021 has been 487, and our total for 2020 was 965. On this slide, you'll also be able to see our average length of stay. So for 2021, currently it is 16 days. For 2020, it's 14 days. Our discharges for 2021 so far is 475, and for 2020, it was 983. And COVID did impact us, by the way, our discharge. The next slide is going to reflect the OSH side, and that is the patient days for 2021 was 20,947 days. For 2020, it ended up being 38,462 days. The average census currently for 2021 is 100, and for 2020, our average census was 106. For admissions, 2021, we have so far 66 admissions, and in 2020, we had 165 total. Average length of stay for OSH for 2021, right now it's been 244 days. For 2020, it's been 237 days. Discharges for 2021, we've had a lot of discharges so far. We've had 86. Social workers have been working very diligently with our community partners in getting people discharged. 2020, we had a total of 162. Okay, next slide. This is a combined AAC and OSH average length of stay. So if you look, we have, for 2020, we had 8.1 people on the waiting list. And then for 2021, we've had 13.1 so far. I know we've been talking about wait times. For 2020, it was 93.64 hours. And a lot of that did have to do with COVID. There's a couple times where we've had AAC, we've had to quarantine one side of the unit due to the number of cases due to some COVID cases that we've had. So that did reflect that number. For 2020, though, we're at 30.79 hours. Next slide, please. So we've really worked hard to this year, and last year we actually started some transparency initiatives, really increasing our communication to all of our staff. And more importantly, I'm focusing a lot on supervisory training, or how our supervisors communicate with their supervisees. We're increasing communication to the CMHCs. We've established a daily phone call at 10 a.m. where CMHCs can call in and ask about people on the waiting list or any triage questions. Also, I hold bi-monthly meetings with executive directors. That's been a great addition. Currently, our hospital is a member of the Rotary, and they've taken it upon themselves to help participate in our backpack project. So all of our patients, upon being discharged, leave with a backpack that has a variety of items that they can use wherever they're discharged to. And then currently we're really focusing this year on restructuring our citizen advisory board. giving it more of a purpose and getting our community members more involved in what's going on here at the hospital. Next slide, please. Increasing strategy and accountability. Accountability is really important, so is strategic planning. And so we've already held a lot of sessions with our 22 departments and just focusing on what our goals are. And then we've also used a variety of accountability tools and systems that we've put into place, such as quality assurance and performance improvement projects. We continue to do leader rounding. That's a monthly occurrence where we increase communication between supervisors and supervisees to ask questions, talk about concerns. So that's really increased our communication as well. On the next slide, this really highlights what I talked about last year, which is equipping our patients. And so one of the things that we've done is we created an animal care and horticulture program here at the hospital. Essentially, we have a mini farm here with some animals, and we are working on really developing an animal assisted program, certifying our clinical therapists and our leisure fitness staff to be able to provide animals within some of our groups and individual sessions. We also have really worked hard on our greenhouses that were already here on campus, but just really teaching our patients about growing food and just some of those other skills. The other program is supported employment. For those that are familiar with it, the patients that want to work here, they work alongside some of our departments. They do have a coach with them at all times. And this year we're trying to take an initiative of having our patients go in the community with their coaches and getting involved in some community businesses. So we're looking at that. The biggest program that's been really a lot of people have put a lot of work into it is our Spotlight Nutrition program. We're actually incorporating our staff and also our patients into this. We have our snack shack we have a lot of signage around campus on the units, but also in the snack shack. So our employees are doing the same thing that our patients are. So that's been really neat. The next slide, please. We had, much like Superintendent Dittman talked about in her presentation, we have the LMHT program, which has an 85% pass rate. We just had a graduating class, and that was a wonderful celebration we had. We also are working closer with community colleges and universities. Johnson County Community College is a new addition to providing clinicals here on campus to the nursing classes. We also are increasing our number of interns in the various professional departments, social work, psychology. And so we have a lot of students right now on campus. So that's been great for our professional development and also for the students. Next slide, please. This year we had quite a few emergency preparedness drills. We went ahead and worked with our county and our city officials doing just various enactments of things. And so we really are developing a good partnership and collaboration with them. KDH&E has been instrumental. They came out and provided a mock survey for us just to make sure that we were following all the guidelines and that we had everything set up to protect our patients and staff. And so they came out and did a mock survey for us. And we also had our COVID survey, and we recently found out we got zero deficiencies. So a lot of hard work and all that went ahead and paid off. So next slide. Everything that's going on, one thing that's been really important is to focus on our morale of our staff. And so we have a very active employee appreciation committee here. We've put on events that social distancing and all that, but just to really recognize our employees, even in the midst of the pandemic, just more events, more activities. And we delivered breakfast to the units for our employees. So that was a really big deal to them. In terms of COVID, currently right now, we have had 88 positives. 85 of our staff members have recovered. Currently, we've had 46 positive patients, and we've had 33 recovered. And my chart's a lot like Superintendent Dittman's there. So on the next slide, I wanted to focus a little bit on the initiatives that we've taken with COVID-19. We established a COVID unit and that is where all of our positive patients go. And we also have provided ongoing education and information to our staff. We have a 24-hour infection control hotline that our staff can call with any questions or concerns. We've had 2 visits from the National Guard to assist us in mass testing before we got our testing supplies. We have also been able to give bonuses to our staff on 3 different occasions. And currently we've had 400 vaccines delivered from KDH&E. We've given our first dose, and our second dose clinic will be February 10th and 12th. We have 207 employees that have been vaccinated. We have 45 patients that have been, 50 patients that have been vaccinated. So that's been really good. The next slide, wanted to talk a little bit about lifting the moratorium. As you can see here, in FY 2021, budget for KDADS includes $5 million from the state general fund to expand the hospital beds to serve individuals with mental illness, meeting the criteria for state hospital admission, focused on enrolling community hospitals as SIA providers through Medicaid. We continue to work on total bed expansion at OSH, and we're also looking at some statutory changes to help support lifting the moratorium. Let's see here. So we were approved for 2.0 million, including 1.5 from the state general fund to increase the licensed beds, and then 5.3 million from the state institution building fund to renovate the Biddle building to become to actually have more certified beds. And so on this slide, you can kind of see where we're at with the renovations. For B2, we have 95% drawings of renovations that have been completed. And for East Biddle remodel, we're at 15 of the schematic drawings that have been completed. In terms of the next few slides, those are talking about our reduction packages. And so I know Matthew Moore went over those. So if anybody has any questions over those, I'm presenting. Thank you.
Any questions? Representative Lynn.
Thank you, Mr. Chair. I'm excited that you have increased your internship and the nursing programs that you have for the students. And I'm wondering what you're doing if to try to maintain some of those at the hospital.
Oh, to maintain the programs there?
No, to maintain the people to come on after they are finished their schooling or after their internship is complete, if you're able to maintain them as employers or employees.
We have. There's been quite a few, particularly in the area of social work, and they do their practicums, and then they end up staying if we have a position open. So it has been very successful in, recruiting for sure.
Representative Ballard.
Thank you, Mr. Chairman. What's the employment like? In previous years, there's been a shortage, and especially in the time you were doing the remodeling and everything else. But where do you stand now with overtime, enough people to work?
Well, I'm going to be honest, it's been challenging. I read the numbers for COVID, and so that has been a pretty big challenge to us in terms of staffing. We also have had some other businesses that have opened up since I reported last year, and we've had reported last year retaining some of our employees due to that. Right now we're just through, and so that's kind of where we're at with our staffing right now. It's a challenge. Some days are better than others, but the main thing is that we're maintaining safety of the units. And so a lot of my supervisors are working the floor at times, and just making sure we maintain our safety through all this.
Would you say overtime is more than expected, or just due to other staff people getting sick, or do you have a high overhead?
We do have quite a bit of overtime right now, including we are paying quite a bit of overtime to our agency staff, our contracted staff as well.
Okay, so that means you're paying a higher rate
Correct.
if you're contracted staff.
Yes.
If you had your druthers, if you could say what it is that you need the most of now to be as effective as you want to be, what would you say?
In terms of like what category of staff?
Yes.
I think the biggest is the direct care, of course. MHDDs, which is our direct care staff. That would be the biggest. The second would be our RNs, for sure.
And one more, what's the hourly rate for direct care right now?
Right now, ma'am, is $13.95, and then for an MHD, which again, that's our direct care, and then for an RN, the starting wage. Let me ask Karina Adamson, our CFO, behind us. What is that? Yeah, starting wage is $28 an hour for an RN.
Well, the morale part, I'm looking at your list. I'm really pleased to see that because I think, when people are working long hours and they're short-staffed and everything else, anything to do with building morale can only be better for the consumers and your patients and everything else. But over time, after a while, gets very demanding. So there's a need there. And you don't have that large enough employment pool to choose, am I correct?
Correct.
Thank you very much.
You're welcome. Thank you.
Many further questions? I just have a couple here. This 42 kind of briefly looks at the wait list. It's by year, which is very disappointing. Do you have any charts that are reflect what your average wait list are better?
As of right now, I don't, but we can get those for you, sir, because we definitely track that.
You do track that?
Oh, yes.
Then I would appreciate actually a daily chart, quite frankly,
Okay.
of how many people you have on your wait list. This doesn't even really even remotely show a picture of wait lists when it's annually. So
Okay.
how many beds are closed right now?
So our B2 unit that's currently being renovated, I'm 26.
How many for COVID?
West Bill, oh, go ahead. Are you going to say something, Scott?
I was just going to have you explain that the way the units are configured at Osawatomie didn't require the same taking full units offline. So you just might explain how you responded to COVID by repurposing some units, because it's a little different than the situation at Larned.
Okay. So we do have our COVID unit, West Bill. That's so that's provided some additional beds because we had to take the patients, of course, that have COVID onto a different unit. B2 was closed because it was supposed to be renovated. However, there have been times where we've had to use that as a quarantine unit as well, just to still have admissions coming in like we were, and then also trying to respect the fact that we've had to place some patients in quarantine to make sure they weren't going to infect other patients if they did have the virus or came in admitted in with the virus. Does that answer your question, sir?
No. I
Okay.
haven't heard how many beds are closed right now because of COVID.
Okay, so right now we have our AAC. Now, one of the units we have in quarantine, so we're not admitting to that unit because it's in quarantine and it will come off in the middle of next week. But we are admitting to the other side. So there's not really any units that are closed.
So you're you're taking all the patients that you possibly can.
Of course.
So, Mr. Chairman, so at Osawatomie, because there were some vacant spaces around, it didn't require taking a unit that was currently being used to provide the isolation and quarantine space that we needed. So there isn't a reduction in the bed capacity at Osawatomie for COVID-related reasons that you saw at Florida. Just the configuration of the buildings are different, and what was available to have that isolation space made that possible.
Very good.
Thank you.
Now, and Representative Ballard probably can speak better to this than I can, but one of your last slides involves the ongoing 100-year plan, quite frankly, for OFF to be remodeled. I chaired this committee in 2015 when it was shut down. I and Representative Ballard put $10 million in the budget to make up for the lack of Medicaid money that we did not receive during that time frame. We've put money in there time and time again, and it just seems like, is this ever going to happen? I mean, we put, what, $2 million in there last year, $5.3 million out of the State Building Institutions Fund. And, you know, that was a year ago at this time, and I see the drawings are now complete. And then on the Biddle Building, 15% of the schematic drawings are complete. You gotta be kidding me. I mean, are we gonna be 10 years down?
Mr. Chairman, no. So the plan that we discussed with you last year and that the legislature helped fund would have put us on a timeline to have that remodeled space in Biddle open in May or June of this year. The only thing that's moved off that timeline is because of the pandemic, and that we had to use some of those spaces for other purposes. And while they were being used for that, we couldn't let architects, engineers into those buildings to work on the drawings and drafting. So I think what we're talking about now is the same plan delayed by 5 or 6, maybe as many as 7 months, but I think it's not more than 6 months from the original plan, with, you know, every intention of we're not going to make May or June, but we're going to do everything we can to hit the end of this year to have those spaces available, and make the other changes as well that the legislature funded for diversion beds and SIA beds. So there's community capacity as well. But we're on, I was going to say we're on track. That's not true. We're delayed. We're on track except for COVID, and have every intention of proceeding with all deliberate haste to get those beds open that we committed to.
Very good. I just hope I'm around to see it. So anyway.
I hope I am too.
Representative Kincannon.
Well, Mr. Chair, you stole my question a little bit. That's the direction I was going to go. And I asked this question of you in appropriations last year, and I honestly can't remember the answer, what your answer was. But, you know, it wasn't that long ago that we were talking about tearing all of it down and building a new building. And I'm just wondering where I was when that plan was scrapped, and now we've gone to putting millions into remodeling these buildings one by one. And we had money, I mean, we discussed funding the demolition of all of those older buildings that are dangerous sitting on campus. And I don't know, what's your response to that, Scott?
Representative Buchanan, so on the raising of buildings, we did make a focused effort in the capital improvements plan for this year to not just identify, we already know the buildings, but to target those for raising. And I just don't have it here in front of me, but we can get that to you, what the that schedule looks like. In terms of the building something brand new, that predates me coming to KDADS. So my best understanding was that in the prior administration there were some proposals submitted from outside vendors to either build a new facility or operate the state hospitals. That's not been the direction I've been asked to implement. So I can share or try to do more research on that, but it does predate me. When I started with the agency last year, this is the direction that I was charged with implementing, and that's what I've been working on. But for the raising projects, we did heard what this committee said, what the full appropriations committee said, what Ways and Means said to make sure we're taking care of those buildings that aren't safe and get those prioritized for raising. And we did that in the capital improvements plan that we submitted this year.
Okay, thanks. Thanks, Mr. Chair.
Representative Ballard. I think she can.
Thank you. Well, I think that's interesting because we have had those conversations, but I would say there was never a final decision made on that project. We talked about what needed to go, what was old, the remodeling. I remember the big deal was the remodeling of the kitchen and what we needed to do. But I think along the line, a way or some way, we decided to sort of leave it alone and try to get rid of what we really didn't need, but try to keep it as a campus. What we asked for last year, well, actually in 2019, we asked Secretary Howard, would she look at give us a comprehensive plan of how we would be able to open up Osawatomie so that it could be voluntary again, since we closed it since 2015. Last January, just a little over a year ago, she came back with our plan, and in her plan, they indicated that they would be thinking about opening it up, Osawatomie voluntarily, in July of 21. Okay, now since then, if you remember, this plan was introduced in January. We didn't really know about COVID or anything else. It was like really by February we started thinking, and on March 19th, we abruptly left and didn't come back until much later. What is the plan for that July opening of Osawatomie to make it voluntary?
Representative Ballard, we won't hit July, and the delay because of the pandemic was in much of the planning. I mean, our time, Superintendent Feedback and her team, her time was spent in planning to keep the staff safe and patients safe. But in the midst of that, we said, well, we need to keep making progress on the remodeling, on the plan that we presented and implementing it. And so as things calmed down enough that we could get engineers and architects into the buildings to do the design work, that's happened. We issued the contracts to make that happen. So the timeline is now pushed from July until, as we indicated in the slides, we'll occupy the new Biddle space by January of 2022, complete construction sometime at the end of this year. So we're delayed by
6 months.
5 or 6 months. I would say entirely because of the pandemic.
Well, you know, that's interesting. We had a forum of legislators in Lawrence on Sunday, and that came up, and we brought it, and I said, I would think just by looking at it, it's probably about 6 months or so. So I'm really pleased that that's about the timeline that we would still like to open that voluntary. So I really am glad that they decided to make that possible, because we really need to have that space, you know, because what we're on the eastern front, Larned is on our western front, and we have to be able to have some places for people to not only either send their patients, but also for people who feel that they really need to have some care and they can bring themselves. So I'm really pleased about that. But I don't think really, and I'll just end this again, that we ever made a decision about what we were going to do with that campus, because I don't think we really knew. But at one point, I think the price tag was so high that people just kind of put it on hold.
until we could get back to it. But thank you so much. I appreciate it, Scott.
Very
You're
good.
welcome.
Committee, further questions? Okay, let's start on with in-person testimony. The first person we have is Amy Campbell. Amy, thank you for being here. You state your name and all the folks you're with, and for the record.
My name is Amy Campbell. I work for the Kansas Mental Health Coalition. Do you want me to take it off? Can you hear me? I'll keep it on then. I don't have any lip gloss on, Mr. Chairman. Just it. Okay, so I have submitted to you some pretty extensive testimony, and I'm not going to go over that in detail because I believe that this committee has really investigated the state hospital's budget for these two very important facilities pretty extensively already. I'm going to try to touch on a few points that maybe just have not been addressed. As the coordinator for the Kansas Mental Health Coalition, and I will just let you all know, if you're not familiar with the coalition, we are a roundtable organization. The community mental health centers are members. We have some private hospitals, the psychiatric society, the social workers, consumer organizations, family organizations like NAMI. We're a broad group. We meet in roundtable meetings every month, and we discuss issues that we can find consensus on. Now, our consensus for a long, long time has been that the state hospitals need to be funded appropriately to provide quality care, to have the capacity to serve the people who need that level of service, and they need to be able, we need to have a plan to expand the availability of these beds and where they are located. Those recommendations align with the recommendations of the 2018 and 2019 Mental Health Task Force that was created by this legislature. Those recommendations align with the Adult Continuum of Care Task Force that was created by Secretary Keck. Those recommendations align all the way back to the 2003 Future of State Hospitals report that was created by under SRS. So there is a mission, there is a plan. Representative Ballard, you characterized it very well when you said it's not that we haven't had the information, but when we see the price tag, then you as legislators prioritize what you can fund and what can move forward. Our organization was not supportive of the privatization model that had come out that would have built a new hospital but had it privately run. We do, however, support partnerships with existing private hospitals to serve these patients so that they are not put on a waiting list when our state institutions are short of bed capacity. It has been very upsetting to many people across the state that COVID has interrupted this path forward that finally felt like we were making progress. But I would say that these reports from the superintendents that you have heard have highlighted many accomplishments that were recommended by the task force, including training, including getting additional students on campus, including a lot of the quality control measures that they've been doing and stabilizing staffing and increasing wages. And there's just a lot of improvements that are occurring. So I don't want it all to sound bad. Having said that, we do not support closing state hospital beds. We will not support closing hospital beds. And it would be our recommendation that if moving forward we cannot reopen them in the way that they've been provided to date, then we need to have a plan to provide that kind of resource in a different way. I will take just this moment to say that the governor does have in her budget crisis money that would be dedicated to crisis response services that will absolutely reduce the need for inpatient state hospital beds. It will absolutely reduce the burden that is put on local law enforcement. But putting resources on the community side, as we definitely need to do, doesn't mean that we don't put resources on the state hospital side. These are parallel pathways. These are absolutely crucial resources. And I appreciate the fact that this committee has really provided a lot of leadership in recent years in trying to make progress. With that, Mr. Chairman, I would stand for questions.
Thank you, Amy. Committee questions for Amy. Representative Ballard.
Thank you, Amy, very much for your testimony. And also, I just want to comment on what you said about the Mental Health Task Force, because we took a lot of direction over the last 5 years from the Mental Health Task Force. I mean, even to the point of renewing that task force because the work that you submitted was so effective along those lines. And you mentioned some of the things we were doing. But I'm trying to think, in part of that mental health, it did say about increasing the beds, because we had that necessity at one point. We needed to have at least 20 new beds, 20 beds online immediately when you submitted that task force, right? So how have we done with increasing those beds that the task force said that we really needed because of the census?
In an attempt to not be depressing, the legislature has enacted a number of those recommendations. The 2019 Mental Health Task Force was reconvened in part specifically to conduct a statewide bed study to say how many beds does the state of Kansas need to serve its population. Under the model that was adopted, we would need 221 additional inpatient state hospital beds. Now, committee members did not think that that's something that this legislature was going to get really excited about. And as mental health care modernizes, we know that we can provide other types of care in the community that reduces that need. So the recommendation was to stand up 36 to 60 additional beds, either within the state hospital or through private contracts and a regionalization model. And that report, I'm afraid that the deadline set by the committee members has already passed for that.
All right, well, I think that's all I have right now.
Committee, further questions? Representative Helmer.
So we have a number of community hospitals across the state that already have psychiatric units. In addition, we have experience through KDADS in contracting with specific organizations for state hospital-like beds. And we've called that, I forget what it's called, the Census Management Initiative, I believe is what it was funded under. So there are barriers to those contracts. For one thing, many hospitals have to take into account who would they admit, the level of violence that that person might have tendencies for, the types of care that that individual needs, the medical needs of that particular individual. So those contracts then occur between KDADS, those private hospitals, and you could think of them as kind of an overflow bed situation. That's something that we have already done. We do it now to some extent. The recommendation of the task force was to formalize this to where you would literally have beds you knew were available in a community. I believe the Mental Health Modernization and Reform Report recommends that those beds be placed within South Central Kansas. If you look at that bed study that was done under the task force, it looks at where beds are currently available across the state. So the contracts occur with providers that exist within the community that are willing to commit to treating a certain type of admission. And there are other recommendations in there as well. If you look at my testimony, it talks about Crisis Intervention Act and crisis intervention centers. This legislature adopted an act several years ago that would stand up crisis intervention centers that could take involuntary commitments. So far, that hasn't been put into operation. We currently have crisis stabilization centers, but we do not have crisis intervention centers in place. So that's another area where we could provide these resources.
Go ahead, Representative Ballard.
Thank you. Tell me the difference between the crisis intervention centers, which is what we also would like to have, and the crisis stabilization centers.
The easiest way to see the difference there is that a crisis intervention center can take an involuntary commitment. And crisis stabilization centers really just exist to provide screening, assessment, maybe short-term stabilization, and then individuals move on. The crisis intervention centers would provide a slightly higher level of intensive care, closer to what you see provided within the state mental health hospital.
Thank you, Mr. Chairman.
Committee, further questions? Thank you, Amy, for being here.
Thank you, Mr.
Appreciate
Chairman.
all you do. And I might add, if some of the folks from Osawatomie are on there, we appreciate everything that you do. This is not any kind of a condemnation or anything like that of the job that you do. We're actually, believe it or not, you might not believe this, but we're actually here to help. So anyway, I just want you guys to know that. We appreciate it. Been around a long time. This thing has been festering out there, and we're doing the best job that we can to help out. So anyway, I just want you to know that. So thank you.
Thank you.
Amy, thank you for being here.
Thank you, Mr. Chairman.
Are you going to do it in person? Are you going to? I'm not sure you can go WebEx out in the hall, so. Yes, please. Kyle Kessler, thank you. You might mention who you are and who you represent.
Yes, Mr. Chairman, and I am Kyle Kessler, Executive Director at the Association of Community Mental Health Centers. We represent, again, all licensed 26 CMHCs around the state. Very much appreciate the opportunity to be here this afternoon to provide testimony on the state mental health hospital budgets. I'm going to depart from my written comments and hopefully succeed in making the points I want to make. But when I was listening to the testimony and the presentations from the state hospitals yesterday and thinking a little bit about even what the chairman just said, when I was growing up on Saturday evenings, Hee Haw was on. And it always started with gloom, despair, agony on me. If it weren't for bad luck, I'd have no luck at all. And that's how the state hospitals have lived for better part of a decade and a half. And it has been one thing or another, and you couldn't have predicted some of these things. So the certification by CMS, no one saw that coming, not even our accrediting bodies like the National Council. Decaying buildings, we thought we were taking care of those in time. Then you run into asbestos abatement or having to get facilities sprinkled. You run into EMR systems that are ready to topple over, which this committee deserves a great deal of credit. And I would say our gratitude for funding last year, because some of the things that people like to fund least are technology projects. But that is literally life-saving. If someone gets the wrong medication because an EMR goes down or they're released prematurely or something gets misentered. So I really appreciate the fact that the KDAD's leadership and the state hospital superintendents are pursuing these initiatives. And, you know, I thought for a second it was possible that you or Representative Ballard might start my testimony for me, because it sounded the same for the last 5 years in terms of the moratorium at Osawatomie State Hospital. We still don't like it. It's painful at the community level. It tests our community relationships with law enforcement and community hospitals. One of the things that people have participated in very collaboratively have been all of the task forces and committees over the years. 2017 and 2018 Legislative Mental Health Task Force that Amy mentioned earlier, and then the Mental Health Modernization and Reform Committee this last year, which you and Vice Chairwoman Lynn and Representative Ballard all participated in. And there was some significant work in those things, and a lot of the recommendations have been the same that we've seen in previous years. So additional beds being a part of that. And each year that goes by, we learn so quick, and and COVID has taught us that too. What we know now is 12 months different, feels like 5 years different from when this pandemic started a year ago. It's the same with the state mental health hospitals, trying to figure out alternative bed scenarios or different things we can do to relieve the pressure on the state mental health hospitals. In a lot of ways, the best that we could hope for at some times is collaborative, responsive communication from the leaders, and I absolutely give the two superintendents credit for that. I think that they must have a competition going to see who can respond more quickly to the concerns that are expressed by their communities, and certainly Deputy Secretary Bruner's leadership as well, I think, has helped the agency. But they are pursuing the initiatives they need to pursue, and we all want these things done yesterday because they were neglected for so long that rebuilding them immediately isn't achievable. But the things like the state institution alternative, we are 1 or 2 agreements away from being able to eliminate the moratorium, and we want it done right. I mean, just to say, all right, there's no more moratorium, that'll just make everybody frustrated all over again when people can't get in. I think the waiting list yesterday at OSH was 18, and so that means that there's a lot of, I mean, that logjam at the community level is something, if you haven't heard about them yet as a legislator, you will, and Larned State going that direction. And I'll conclude my comments really by saying, you know, you've heard the bulk of my comments the last several years being about Osawatomie State Hospital. It would now be about Larned because of that piece of the budget that continues the 72-bed funding level. That would be our chief request to this committee, is to undo that and restore that, because that's not sustainable. I think best case scenario is that they would end up finding 18 beds somewhere else in Hayes or Garden City. If you're diversifying beds, that's one thing. Eliminating beds is a non-starter for us, and you'll see us here again bringing it up at later points in the session. So with that, Mr. Chairman, I would stand for questions.
Any questions? Representative Concanon.
Just a quick one.
I don't know anything else about HEHA, Representative Concanon, and that I exhausted my knowledge if that was going to be what it was.
Too young for that. Now you mean, okay. So a few years back, we worked on a bill for psychiatric students, loan forgiveness.
And Bill 33, one of those, yeah.
So I just wondered what the status, are we seeing anything come of that, or how, I mean, it's got to be in place long enough for the students to have gotten through school.
Right. My response to that would be that we've had a lot of trouble getting the data. I think that program was to be implemented through Board of Regents, and we asked about it last year, and I don't know if they hadn't had interest, or I'd heard of one student. So that would be something good for us to follow up on for sure, because that piece, and also as it relates to, this will be a second dose for Representative Lynn and Representative Rees of hearing me talk about CCBHCs, but competitive pay is an incredibly important part of recruiting and retaining psychiatrists. Missouri has that, Oklahoma has that, and they've seen their turnover just shrink very, very quickly, and the salaries have gone up for the docs, so that's where they're going. So yeah, that loan forgiveness is a very, very important part, so we need to follow up on that. Thank you.
Thank you.
Representative Ballard.
Thank you, Mr. Chair. You know, one of the things I think, you know, we're very proud of is, you know, when we looked at the mental health task force, as well as Chairman and myself, we really wanted Osawatomie to be open. And I have to say, we gave that task, as I said earlier, to Secretary Howard, and she delivered. She told us what it was, and we said we wanted it in January, and she presented it to us in January. And so we know it's off track just a little bit, and most of that is COVID along those lines. One of the things that I've heard you stress, and I also heard Amy Campbell say it as well, that closing those beds It's just not something we can do. And after the task force this summer, where we talked about mental health reform and modernization and everything else, to go that route, that sort of like closes the door on a lot of things we talked about. Can you just touch briefly on what our task force really maybe proposed that fits in with this mission?
I think I got lost somewhere there. In terms of the mission, meaning getting it opened fully back up in terms of taking voluntary admission?
That as well as reform of mental health.
Well, I think that community-based services isn't just specific to outpatient treatment. I think it can also be done and that's something we lost years ago. I mean, there were at least 3 or 4 community hospitals that had psych units on them that closed, either just shutting down the units altogether, probably half a dozen in the last 5 years, and or else turning it to oncology or cardiology or something that had a higher demand and probably better reimbursement. So I think if we can get more community beds back, that would be a very significant approach. And also that South Central Kansas regional hospital idea, I think, is a good one as well. I think South Central Kansas, we just saw with KVC's opening down there, them having youth resources that otherwise would have been in Kansas City or Hayes. So then Hayes closed, and so now I want those back too, because there really are those 3 regions of the state. When I think about right now, Butler County by statute is supposed to be going to Osawatomie, but because of the bed capacity there, they need to go to Larned, and that's through a memorandum of understanding and agreement. I think Sumner County might be the same way, but if we had South Central, then it would put, if we had some number of beds down there, say 30, that would put both state hospitals in a very, very different situation, I think. And probably you have a better opportunity with workforce. I mean, I didn't even mention workforce depletion, certainly in Western Kansas and also in Miami County. I mean, that's one more obstacle that both superintendents have. But yeah, the South Central Kansas piece would be significant, and with the idea of Sedgwick County folks having to drive 2 hours one way for inpatient, it just stresses that part of the state tremendously.
Very good. Thank you so much. Thank you, Mr. Chairman.
Thank you, Representative.
Any further questions? Seeing none, Tara, are you on?
I am. Can you hear me, Mr. Chairman?
Very good.
Very good. Well, thank you so much. I'm Tara Mays with the Kansas Hospital Association. I really want to thank you all for allowing me to join you today to talk a little bit about what you've been hearing about the past few days. And I just want to echo all of the comments that have been made here. We at the Hospital Association stand ready to continue partnering with these important and essential organizations. As we all are well aware, COVID-19 has kind of provided some challenges, and where there have been chinks in the armor to our state systems, this sort of pandemic environment has really shined a light on some of the areas where we can make improvements. And so we wanted to just update you on some of the issues that we are hearing about at our hospital association. While our hospitals remain committed to giving patients the right treatments at the right times, we are noticing the impacts of some of the things that you all have discussed today: added wait times, added evaluation times for our patients that arrive at our member hospitals. This has all been occurring at a time when our hospitals, while we remain committed to COVID-19 response, strategic deployment of our limited resources really does continue to be imperative, and staff and time are more critical than ever to be able to appropriately triage the care, not just to these patients that need behavioral and mental health services, but to all of our patients with a wide range of needs. So our member hospitals, just to give you some kind of analysis of what we're hearing, have experienced some pretty significantly increased wait times in transferring and getting evaluations for our patients in need of behavioral health treatment. We've heard some examples of our hospitals that have been holding patients for up to 5 days while awaiting bed space at the state hospitals. We have some emergency departments that have reported the impacts of that in caring for other patients as they wait for evaluations for mental and behavioral health services. We appreciate the partnerships that we have, but that delay in providing care really does add to the stress to an already strained system. And we only bring this to your attention today to really point out the importance of some of the recommendations that you all have made as you've worked on the recommendations during the Special Committee on Kansas Mental Health and Modernization Reform. Specifically, to your question, Representative Ballard, we would definitely point to recommendation 2.2 of those committee recommendations that really does kind of point out and highlight the need for a comprehensive, well-funded plan to address voluntary and involuntary hospitalization for inpatient capacity needs. We appreciate all of your work on that, and we look forward to continuing to partner with our partner organizations to solve this problem going forward. But I'd be happy to stand for any questions.
Questions? I think for clarification, Tara, the reason they're waiting for assessments is an assessment only lasts 24 hours. Is that correct? By the CMACs?
You know, Mr. Chairman, I believe that is correct.
How long does your assessment?
Mr. Chairman, Kyle Kessler with the Association of Community Mental Health Centers. Representative Reese actually knows this issue probably better than I do. She used to, go ahead. I was going to say, it's supposed to be 24 hours, but it's the screening is supposed to be good for 5 days. And so it depends on, and again, depending on which hospitals that Tara's referring to that are having the problems, again, the difference at Larned State Hospital now having sometimes 24 or 36 or 2-day waits, they were not used to that. And they absolutely, I mean, you think about the potential of driving from Goodland or Colby to Larned, that's as far as it is to get to Osh from any point in the eastern side of the state. Larned has the western 2/3 to contend of the state geographically to contend with. So that would probably be one of the difference makers. Does that sound right, Representative? Did I say that right?
Next time I'll ask Representative Reese.
Yeah, I don't need to be here.
Yeah. Good. Thank you. Thank you very much for that answer. Any further questions for Tara? Thank you for testifying today. We appreciate it. Okay. Next, I have Sheriff Scott King. Sheriff, are you on there?
Yes, sir, I am.
Very good. Take it away.
Thank you. I'm Scott King. I'm the sheriff in Pawnee County. Thank you, Mr. Chairman. Thank you, committee members. I've had the pleasure of listening for the past 2 days here. And I'm here to talk about the mental challenges of law enforcement that other members have brought up. It has always been a problem for law enforcement when we deal with mental health challenges. But it really started for us on May 5th when we received what was known as an immediate release from KDAS that was provided to the courts. And part of that was when they cut the 90 to the 72 beds at the Larned State Hospital. It seemed like for law enforcement, the rug was pulled out from underneath us. So on May 7th, the Kansas Sheriff Association president, Cole Presley, wrote a letter to the governor. And also CC to the governor was Secretary Laura Howard with KDADS, Deputy Secretary Scott Bruner, KDADS, Will Lawrence, the governor chief of staff, and Commissioner Andy Brown, Kansas Department of Age and Disability Service under the Behavioral Service Health Services. I am not sure if anybody did answer back to the Kansas Sheriff Association because we've been dealing with this since May 5th of this year because of COVID. To me, it didn't seem right, and I'll just use that term because now we are in a national pandemic and now law enforcement is trying to deal with the mental health challenges. Part of that that took place to try to get somebody into the Larned State Hospital was a 5-step waitless procedure, which includes we have to screen them. The screen has to go to the Larned State Hospital triage. Larned State Hospital has to review and approve the admission. There has to be lab work done. And at the very least, number 5 is when the doctors from our emergency room talks to the Larned State Hospital doctor. Now, these are people that are having real-time crisis. They haven't been in our jail usually because we cannot put somebody in our jail unless we have a criminal charge by statute. So what are we supposed to do with these people? And we continue to ask that question. I have a few examples, and I just want to be able, if I may, continue to read them to let everybody better understand what we put up with. The first one I'd heard about was when the Dodge City Police Department was dealing with a person in real-time crisis. There was no criminal charges against this individual, but he was needing help. And for 36 hours, the Dodge City Police Department had to supervise this individual in an interview room while this individual in a real-time crisis was waiting to go to the state hospital. So what do we as law enforcement have to do for this person in that 36 hours? Medication? Food? Clean clothes? This is a disservice to this person. I was talking to the chief of the Larned Police Department just the other day to get a few more of his incidences that he's had in Larned. He's had anywhere from a 4-hour wait to a 12-hour wait with 4 officers that had to be utilized and a 10-hour wait with 3 officers that had to be utilized. Myself as sheriff, who had criminal charges, one was an inmate that had to be screened, and for 12 hours we had to sit one-on-one with this inmate in my jail, and then he was able to go out to the state hospital to be transported. The other one was a 40-hour wait. Yes, he stabbed his wife. Yes, he sliced his own throat. This individual needed help. So we followed the procedure, and the procedure failed us. So once we took the individual to the hospital to get medical help first, then he was screened. After being screened, then the hospital, state hospital, and our hospital started talking on what needed to be done to get him out to the state hospital to help him. And nothing helped him. Nothing. The doctor at the emergency room had to look at him twice. We had to bring him out of the jail once after the state hospital wanted him to be medically screened again, and nothing. I have a 16-bed jail, and we are fighting COVID like everybody else. That is not an excuse. So we end up transporting this dangerous man who only received medical treatment and transport him to the Ford County Jail to the sheriff out there who was willing to help. I was told to call back on Sunday. This was on a Friday, Saturday. I was told to call back on Sunday, which we did, and we were denied again to take him out there. On Monday, we called back out to the state hospital, and they said yes. So we took a team of deputies, went back out to Ford County, and brought him back to the state hospital. What did that do for him in that time? Nothing. He got screened, but he wasn't getting any help. Medically, he was okay, getting stitches in his throat, and then he was worried about his wife because he had stabbed her. I know of Barton County had an incident with an individual with a knife. They had to end up charging him so they could hold him after being screened because there was no place to go with him at the state hospital. And I believe it was 3 days later after that where the sheriff was able to take him to the state hospital. I had a 73-year-old lady who had just purchased a gun, who lives in McPherson, who went back to a little town of Garfield on a Saturday morning. She had sold the house, but her husband was dead, her son was dead, and she put the gun to her head. My deputy got over there once it was called in. I responded. We talked her down. We took the gun away. I called an ambulance to get her some help. They transported her to the hospital. She was screened. There was no room. She walked out. We ended up helping her get a hotel room in Larned. We took the gun. She had a dog with her. We dealt with the little dog. We helped her the next day to get her vehicle back to see if she needed anything else from us. And that's not challenging. And everybody wants to close from 90 to 72. I talked to a sheriff in Lyon County a while back too. He was on a 4-day waiting list. I talked to the Greenwood County Sheriff who was on a 2 to 3 day waiting list. They didn't know what to do with this individual either, but they dealt with it. So where are we supposed to go? Are we supposed to put these people in crisis, in a real-time crisis, in an interview room, in a squad room, in the back of a patrol car and drive them around? It's my understanding that the average of last year for the state hospital or the year before, the average was 76. But the governor, or Laura Kelly and Laura Howard, decided to take that away from us, those 18 beds. I'm not happy. And I was in a Zoom with Representative Carpenter and other representatives Monday. And we don't know how to handle this, especially when it's a disservice to the person in crisis. And we need help. And this star that I wear represents law enforcement, not just through the state of Kansas, but throughout the nation. What do we do to help out law enforcement? I'm sorry I don't have any fancy charts or fancy data. What you get is what you get from me, okay? Good or bad, this is what you get. I've got 35 years with this same agency, and this is what we've been dealing with as the state hospital is in my backyard, 3 miles out, and I have to wait 12 hours. 35 hours, 40 hours. I feel sorry for the other agencies that have to drive from Colby. And especially if that person is violent. We do get violent people.
Sheriff, we
It
do.
doesn't mean we have a criminal charge for them because they need help. I realize I've gone off my testimony just a little. I'm trying to get back on the rails here. But it does upset me. It upsets me because on July, I put it on Facebook about what happened to the Dodge City Police Department and my agency. I get a phone call from the superintendent, Lisa Dittman, to see if I would have a phone conference with her and Scott Bruner. Now, nobody's ever reached out to me before. And I did. I want to play nice to a point. But then after that, nothing happened. So I have two more. I sure wish I was standing in front of you because I love holding up newspaper articles. One of them says, KDAD's creating stress for the area law enforcement. That was on August 27th. The one before that was December 10th of this year. And it says major stabbing incident Friday delays in Larned State Hospital admittance frustrates sheriff. Now, today I was called by the Edwards County Sheriff. Now, and I've been in contact with Lisa Dittman today because there was some waiting list hours that seemed to be having a little difference. The sheriff of Edwards County told me it was 12 hours starting last night when they picked the individual up at 10 o'clock at night. Did not get screened until 2 o'clock this morning. And then the sheriff told me that at 8:50 this morning, they were told that the individual was admitted into the state hospital that they could bring him. Kiowa County Sheriff, the same way. And I just received a text a little while ago from that sheriff. This was around, I believe, 3 o'clock, 2:30 or 3 o'clock. And they had been dealing with an individual since 7 o'clock this morning.
Good, Sheriff. We appreciate your testimony. I think the committee has heard you loud and clear. I think at some point in time, you need to weigh in with your legislators when we take these budget requests to our appropriations committee out of this committee. And I'm very sure that we will continue to operate 90 beds at Larned State Hospital. So I can tell you that much right now. This committee will recommend that.
Thank you. Thank you very much.
You're welcome.
Thank you. Thank you very much.
And thanks for what you do.
Well, thank you.
Committee, that concludes. We have written testimony from Ed Klump. I think you had that. Ed, are you on there? Did you want to say a few brief words?
I am, Mr. Chairman. I'll be very brief because I know I'm standing between you and dinner, and I think I heard a couple of stomachs growling. You heard Sheriff King's frustrations, and he pointed out that that's been from what happened since May the 5th of this year. In eastern Kansas, we've been dealing with this for over 5.5 years now. Moratorium went into place 6/21/15, June 21st, 2015. So it's been a little over 5.5 years. On the back of my testimony that I turned into you yesterday is some bulleted items that I put together for just some general recommendations. There's probably a couple we'd add to that, knowing what we know today. One, obviously, we're going to oppose any bed reductions. Bed reductions at a time when we're still have waiting lists doesn't make any sense at all. And we also support the governor's recommendations for the $5 million adult crisis services and the $3 million for youth crisis services, especially with that add-on to try to extend this out to the rural areas. And so that document is there. And today I submitted a separate document on behalf of the Sheriff's Association talking specifically about competency, because yesterday was the first we'd heard that the governor's recommendations was recommending closing 30 beds permanently. in the unit that deals with competency. And I put some information in there trying to explain what competency is. I'm not going to go through that, and why that's important to us and the problems it creates for us. And Mr. Chairman, I think you adequately covered that earlier in some of your comments as well. So, Mr. Chairman, thank you for the opportunity to speak, and I will just stop there. But if any of the committee members have any questions, they know how to get hold of me, and I'll be glad to talk to them, talk with them about their questions.
Very good. Thank you, Ed. Committee questions of Ed. Ed, we know how to get a hold of you. So
Yeah.
Thank you for being here. Very good.
You're welcome.
Okay, committee. I do have a couple of recommendations here. We will go ahead and take recommendations on Monday morning, but I do have a couple of recommendations here. I make a motion to add $232,554, all from the SGF, to provide funding to maintain the bed capacity at Larned State Hospital at 90 beds, and add the language requiring those beds to be reinstated once COVID-19 isolation needs have ended for 2022. Do I have a second? Second by Representative Helmer. All in favor say aye. My second motion is add $2,191,550, all from SGF, to provide funding to reopen the 30-bed male unit at the State Security Program at Larned Hospital, and add the language requiring those beds be utilized once COVID-19 isolation needs have ended for 2022. Do I have a second? Second by Representative Howard. All in favor, say aye. Aye. Opposed, same sign. Motion carries. I'm waiting on some other language that I do not have at this point in time that kind of codifies that. So I apologize for not having that. Committee members that have been here before, I'm usually a little more organized than I have been. But anyway, we will have a few more recommendations on Monday early in the committee. And committee, I might mention about Monday is we're going to do the budgets, and then we're going to have an informational hearing on the ERO number 47, combining KDADS and DCF. And committee, I might add, these budgets are intertwined with KDADS. So a lot of the issues with the state hospitals and the funding are going to be in KDAD's budget. So we're not done here yet for funding. It's kind of wrapped in there, and we can further make recommendations in KDAD's budget depending on the issue. So we'll deal with that when we get to KDAD's budget. So any questions? Representative Ruiz.
Thank you, Mr. Chair. Will we get any information ahead of time so that we can look at if we're going to look at budgets or something, that we get them ahead of time, like as soon as possible, just to review it, because otherwise it's really hard to make decisions without having had time.
And I don't disagree with you at all. We got our budgets quicker than a lot of committees did, but they were literally hot off the press, and so I think they're getting caught up in research, and I'm hoping we should get these next round of budgets. I mean, everybody has just been working hard to try to, do this expedited process. Normally we have a lot more time than we do, but because we're concerned that any day now with somebody coming down with COVID and, half this committee being quarantined or, all that kind of stuff. So it's an unusual year. Normally we have more time. I'm hoping that we do get our budgets quicker so that we can actually view those.
I just want to go on record that voting on budgets like this is really difficult. without having enough time. And I understand, COVID is messing everything up, as we heard, what it's doing to the state hospitals. But not having enough information and having it in time to ask intelligent questions, it's just really hard for me to vote when we do that. So whatever, I know you will do your best to get this information to us, and I appreciate that.
A lot of it is from the agencies, and I'll see if I can't get those from the agencies quicker because, we didn't get these, all this breakdown here. And I do think you do have electronic copies of the budgets themselves.
I highlight on the.
Yeah, and that's what we have right now, but I will talk to the agencies about getting at least their deal out. And I understand exactly where you're coming from because I mark these things up and then, because.
I learned from you from last time.
Yeah, exactly. You see me walk in with a big old stack with yellow pieces of paper hanging out of them where I have written on. So, exactly. So I will reach out to the agencies and see if we can't get that in a more timely manner.
Thank you.
Committee, further questions? We are adjourned.